My name is Maurice Dusseault. I'm a member of WISE for many years. My work is mainly in geomechanics and subsurface energy issues. But because of my background in geophysics as well, we've come up with an idea that we'd like to try out. I'm titling this Helping People Breathe, but we call it vibratory pulmonary drainage simulation, trying to help drain the lungs of people that are suffering from COVID-19 crises. So COVID-19 issues, there's no vaccine, there's no robust treatment. Some patients, for different reasons, mostly those with other syndromes like obesity, they experience severe. And Jessica, you've muted me.
You're unmuted, Maurice.
I'm unmuted? Okay, great. So in COVID-19 issues, once intubated, the prognosis is not good. On average, we have over a 25% death rate, and it's highly variable among jurisdictions, depending on how early they intubate and many other factors. Lung congestion, lung blockage seem to be major issues. So as a mechanical person, as opposed to a biological person, I am wondering whether mechanical approaches can help us treat patients to get better outcomes. So this is what a ventilator looks like to help people breathe. And I want you to notice in the background the bed. Notice the bed very carefully, okay? We'll come back to that later. So what do we do in trying to cope with COVID-19? Well, we try to avoid. We try prophylaxis, disease prevention actions such as chemicals, bioagents, diet. We use treatment, anticoagulants, inflammation suppressants, etc., and of course oxygenation through intubation, either through the mouth or through a tracheotomy. And of course, the advice from Alberta Health about 2 months ago almost now is that all admitted COVID-19 patients should receive prophylaxis to avoid hypercoagulation. In other words, chemicals that stop clotting of the blood in the circulatory system. There's other things like this hydrochloroquine, which has been in the news a lot, and it is still unclear as to whether or not there is any benefit from it, although there's a claim here that it helped prevent COVID-19 in the workers. And many articles discussing the lessons that are learned, but things are not really very positive. So here are some of the chemistry and biology suggestions, and there's many of them, of course. Alpha blockers, anticoagulants, inflammation suppressants, etc., to reduce cell damage. And the efficacy of these techniques is not well defined at the present time. We know that Bonnie Henry has done a stellar job in British Columbia from the very beginning, thanks in part to her SARS experience. And BC certainly leads Canada in terms of response to this pandemic. And here is a statement from BC a few weeks ago. There are no proven therapies. I'll just go to the bottom phrase. Patients should be aware of the risks and benefits of novel therapies, and with efficacy and safety data collected to inform the larger community. In other words, we don't have strong, proven therapies at the present time, and there seems to be little prospect of that until we have a vaccine, some form of a vaccine. So serious problems lead to intubation. And again, I want you to notice the head-up position of the patient. In my view, the head-up position is the worst possible thing that you can do during intubation. I'll come back to that. So as the killer strikes, it proceeds down your respiratory tract into your lungs. It impacts the alveoli, infection, inflammation. If your body reacts excessively strongly, then you get into this cytokine storm, and you're in real trouble. cellular damage, detritus from the broken down cells accumulates in your lungs, fluids pool, and oxygen take up declines. Death may be from oxygen starvation. It may be from sepsis in the organs if the COVID-19 virus gets into your internal organs. So focusing on the lungs, here's the lung structure with the major distributary tube, the trachea. And then we have, of course, the bronchi, which is the reticulated network that distributes the air to all of the alveoli. Those are the little alveoli sacs. Each one contains a number of alveoli. And we have 300 to 500 million alveoli. And the internal surface area is 50 to 75 square meters in order to aid the diffusion of oxygen into the blood. So at a small scale, we have the bronchi, again, bringing in the air. We have the alveoli sacs, comprised of a group of alveoli. We have the capillaries. And we have the blood flow coming in and going out. Coming in, oxygen poor, going out, oxygen rich. Arterial blood is oxygen rich, venous blood is oxygen poor. The single cell thickness membrane between the internal part of the alveoli and the capillaries is good for oxygen diffusion. So inflammation appears to be focused in the region between the capillaries and the single cell wall of the alveoli, leading to damage and cell death, and that's a problem. And you need to enhance oxygenation to sustain patients, to keep people alive. It also is linked to a diminished ability to clear debris and mucus from the lungs, because you're on your back, your head is up, you've got a tube down your throat, and you can't cough. So any lung clearing technologies should help oxygen transfer unless the membrane is totally destroyed. And it may be that early on in the congestion phase and post-treatment as well, and for other lung ailments, that mechanical aids and mechanical vibrations might help the process. So we're going to go through some clues here. Here's an ultrasound lung assessment, and ultrasound allows you nowadays to do real-time imaging of the lung condition, and that's really good news because we need a metric to measure our success. So it's really valuable. Here's something else I downloaded recently. On the bottom it says the patients have increased work of breathing, fatigue, or a worrying trajectory. That increased work of breathing and fatigue, that's my emphasis. And that's a concern. They cannot drain their lungs. So let's look at some clues. In cystic fibrosis, back thumping helps clear the lungs. It helps get the mucus or the phlegm out of the lungs and allows better oxygenation, allows cystic fibrosis patients to breathe more easily. Please notice the head down, tilted position. In the oil industry, and that's my background in part, the energy industry, the oil industry, we know that vibratory energy can help clear the particles that block a wellbore and allow better production of oil water from a water well, because a water well will also become blocked with particles. Broad frequency and low frequencies are needed to loosen the debris and help clear the passageway. Another clue, at a much larger scale, in fact, is creating transit the reservoir, and that improves the flow water or oil liquids in the pore structure. You create a very strong high amplitude pulse, and it actually dilates the pores and helps take the fluid in and expel the fluid outwards as the pressure pulsing waves pass through at a velocity of about 45, 50 meters per second. Very, very slow waves. Low frequency and high amplitudes are necessary. Another clue from steam-assisted gravity drainage technology, which has been developed and perfected in Alberta and is now more and more being used worldwide. We put in steam, and the steam rises to the top gravitationally, and the hot oil that is being melted by the steam, it goes down to the bottom to be produced. In other words, the vapor phase rises, the liquid phase drops in gravity drainage. I found this from a few weeks ago. Letting patients lie face down boosts their chances of surviving. I would also go further. I would say lying patients face down with a tilt angle of 5, 6, 7, 8 degrees will be even better. The prone positioning reduces the pressure put on the lungs, allows the airways to more easily open, and surely we can design a bed that can do this and help the process. So gravity drainage is important, and in a little bit of levity, here's a good example of the impact of gravity on a well-known drink, the B52, which contains different fluids of different density. But the key thing is that the light fluids are on top. You could put a little bit of vodka on top and it wouldn't mix because it's lighter than all of the three others, which all contain more and more sugar. Going back to another clue, the improved ultrasonic imaging that we can now use to monitor what's going on. So here's our proposed solution, and we'd like to try it out. We would like to develop a suitable mechanical aid for lung drainage, but we know now, because the different scale of the alveoli, the detritus, and the lungs, we know that we need low frequency and high amplitude energy, vibrational energy, to aid the fluid flow. We know that we need higher frequencies to activate the small particles, and we need ultrasonics to allow real-time imaging. And we need, in other words, a wide range of frequencies. So that means we need different transducers that we can control, both the frequency and the amplitude. We know that we want patients face down, somewhat tilted. We want to monitor oxygen, respiration, blood pressure, sputum, other signs to try to improve and optimize based upon metrics, based upon measurements of what is happening in the lungs with the ultrasonics. So essentially then we have really 4 different systems in the process, all computer controlled for amplitude and application and frequency. Okay, so what we're doing is we're transferring energy into the lungs, and we can use various techniques to do this. But there's something also quite important. We can start making particles move, and that can help them. But the last item is important. It appears that mucus and phlegm are shear thinning liquids. I'll come back. So on the left, you see a phased array, which allows you to create a wavefront, or if you're trying to do a medical procedure, you can actually focus these waves so that they focus inside the body at a point. And that's how we destroy kidney stones, using ultrasonic frequencies. And you can see an old image of a fetus in utero on the right. We know that we can transfer quite a bit of energy acoustically with low frequencies. So if you set your speakers on very low frequency and you have the right kind of technology, you can actually charge your cell phone. This technology does not exist, but it was written about in Scientific American about 6 years ago. We know that we can heat tumors inside the body by focused ultrasonic approaches, Australian work. And you can even buy what's called an ultrasonic particle mobilization device to clean your skin with ultrasonics. Hey, I don't know if this one works, but personally, I'm not going to rush out and buy it, but we're transferring mechanical energy into the flesh, into your skin. And the electroflow airway clearance device, which is a 1 frequency thumper, has been used by some people for airway. Now, we know that ultrasonics can reduce the viscosity of some crude oils. We also know that low frequencies can reduce the viscosity of a liquid by shear thinning. Mucus, phlegm is strongly shear thinning. Low frequencies carry much more energy. So if we can vibrate this material, the viscosity will drop and people can drain their lungs more easily then. And you know this because when you put ketchup on your hamburger, the ketchup is a shear thinning fluid, and you have to create some shear in order to get it onto your hamburger. Do the experiment yourself. At a microscopic scale, the detritus and the particles that are blocking the pores in a porous medium, this would be, say, a water well from which you're trying to extract groundwater to drink. These tend to block the pores, like you see on the diagram. And I'm just going to skip to the next slide here because I want to draw the analogy between this and the, excuse me here, I have to, okay, great. The analogy between this and the porous structure of your lungs. So the vibrational energy brought to bear on the fluids and on the particles help perturb these blockages, cause shear thinning, dislodge particles, and help everything move faster. So our model of the alveoli looks something like this. The alveoli in this case is filled with fluid because you're lying on your back, head up, and that allows fluid to pool in your lungs, not drain. And you've got detritus that is blocking perhaps blocking the mouth of the alveoli. But we want air in these little sacs. So we apply vibratory pulmonary drainage stimulation using vibrational energy that has high accelerations. It helps dislodge particles and mobilize these fluids. The phlegm undergoes shear thinning, lung drainage, better oxygenation. That's our hypothesis. That's what we want to try because we believe that the outcomes for all types of pulmonary disorders would be improved. We don't know exactly what a device will look like. This is very much of a preliminary prototype in terms of scale. But remember that we have to have a device that's going to allow ultrasonic energy to image. We're going to have ultrasonic energy, perhaps in a different frequency range, to excite the small particles. And we'll have other transducers. Some of them are called Langevin transducers, and acoustic, subacoustic transducers, in other words, very low frequency, combined in one instrument so that we can do viscosity reduction by shear thinning and fluid excitation simultaneously while watching the images to see that we are indeed lung cleaning. And please understand that the metrics are quite important here. We want to be able to see progress. Here's how we want to do it. Instead of the therapist thumping on the patient with hands, the therapist is using a device, computer output, screen monitoring. The patient is on blood pressure monitoring, blood oxygen monitoring, lung respiratory strength monitoring, etc. And we want the tilted position to promote gravity drainage of the lungs, even with intubation. So this is a doctor in Essex in the United Kingdom who said the majority of your lung is on your back, not on the front, and by lying on your back, you're closing off more of the smaller airways. This is not a good position during a period of infection. I agree 100%. And I want to add that I would like to see the patient during active lung clearance being tilted at 5 to 10 degrees in a bed that can do that easily. Here is, from the same news article, here is a view of patients on their stomach, not on their back. And surely we can design a more comfortable bed that will allow patients to drain their lungs more effectively with the addition of the vibratory stimulation. Help patients breathe. That seems to be a critical thing in the treatment of COVID-19 and also in the treatment of other respiratory syndromes that cause blockage of the lungs by phlegm, mucus, and by cellular detritus that is sloughed off as the inflammation continues. So there are other biological and medical and chemical agents that may very well be partially effective, but we think that if we can get oxygen to the lungs more freely, more effectively, then we will at least not have patients drowning from oxygen, drowning in their own lung fluids, essentially. Then that's what I see every time I see a patient sitting up, intubated, face up. I just shudder and think we've got to do better than that because that contradicts a few laws of physics. So maybe this is not direct linear thinking because I'm a bit of a geophysicist myself, but just like we have a refraction of waves through a block of glass, the refraction of ideas through different disciplines might help a little bit in coming up with better treatment techniques. And this is one we'd like to develop and try. Thank you. And if there's any questions, please unmute your mics or send a chat and I'll try to answer the questions.
Hi, not really a chat, but one of the suggestions is massage beds. They're actually already preset for laying down that way. That might be an area to look at first.
That's a very good idea. My daughter is a doctor, and I did talk to her about that, and she said that there are beds that allow a bit of tilting and that allow a face down position. They have a name for it. They call it the Trendelenburg prone position. So yeah, we're aware of that, but we don't see them being used for COVID patients, and that's a concern of mine. Yeah.
Correct.
Thank you.
Yep. Yesterday, my grandson was over. He's got a tracheotomy tube. He was born 24 weeks, so he just turned a year yesterday, and I did an experiment for you that might have some interest. Anyway, with a tracheotomy tube, he gets lots and lots of fluid in his lung, exactly like you're talking about. And so on a regular basis, they're actually suctioning him on all day, every day. And it's, it's quite a tedious experience. Now, it just happened that he was sitting on my knee and I had my hands around his chest and could feel he was very rattly. And it was interesting when he was suctioned to actually feel it come from the lower extremes through that 4-inch suction tube. And I actually got to feel the difference on what it meant from going rattly to clean in an instant. It was quite, I'd seen it done 1,000 times, but I'd never felt it done. And it's very interesting in that case to actually feel what the difference is in his case. So it's very analogous to what you're talking about. Basically, how do you get that out? And of course, with a tracheotomy tube, you just take the the filter off and shove a 4-inch tube down there and suction things out. But I actually felt it come right out. It was really uniquely interesting and something I hadn't expected.
Well, the experienced massage therapists that have been trained and have a lot of experience in treating cystic fibrosis patients, and by the way, this is usually a person at home that is helping to take care of the cystic fibrosis patient. They put as much as 10 to 12 pounds force with each one of their blows. They cup their hand like this and go whomp whomp on the back. Well, what that is low frequency, high amplitude excitation of the fluids in the lungs, giving you that shear thinning. And it seems to me that if we could extend the range of frequencies to handle things like loosening that detritus, but the low frequency thumping, then we would have a lot better outcomes. But nobody's ever developed a tool that can vary the amplitudes and the frequencies in such a way that we can actually do optimization in a clinical environment. So that's kind of our hope that we could possibly do that.
Just another one, like you're talking about low frequency ultrasonics, and one of the things I've used on my back is, I don't know if you've seen Dr. Ho on TV with his electrical stimulator.
Yeah.
Have you ever used one?
Yes, I have. I had some knee problems a few years ago, and they did it on my thigh right above my knee to try to help, and I have no idea if it helped. I didn't have any good metrics. Excuse me. That's a problem, Mark, is that those therapies don't have easy metrics. Whereas we know that if we have an ultrasonic imager, blood pressure, respiratory, measuring the respiratory efficacy, and measuring blood oxygenation all at the same time that we're treating a patient with a device that we can replicate, then we've got something we can work on, because we can measure in real time how the patient is responding. And then we can vary the amplitude and the frequency of the different frequency ranges and optimize it for different patients that may have, different properties, somewhat different properties in their lungs. For example, a young person, a child might have different elasticity in their lungs than a person of my age. I'm 74 later this year. And it might mean that we need somewhat different amplitude and somewhat different frequency. On the other hand, I'm a big guy with a big chest, so I can take a lot more amplitude than, say, a small woman, a 95-pound woman, who might be bruised by the impact of a massage therapist that force per impact.
Yeah, more what I was thinking of there was the fact that the contact probes seem to work so well. Like on a little battery, you can go for months and months, and it does actually sink very deep, and it's basically waves that you're putting in. I was just curious whether that might be a better method to deliver the waves from the ultrasonic, because those seem to get good surface contact. Not unsimilar to what's on the guy's back right in the picture there.
Right. Yeah, it's there's surface contact, and then there's also severe attenuation. With the high frequencies, the waves don't travel very far.
Right. Yeah. But if you were to connect onto the end and drive low frequencies through there, I don't know that. I don't know if it would pass it as well, because
yes, it does. This is a well-known characteristic of vibrational energy: is that low frequencies travel huge distances without as much attenuation. That's why when you hear lightning, when lightning strikes, you hear the thunder. If you're very close, it's a huge crack that has all of the frequencies in it. But if it's 10 kilometers away, you only hear the low frequency rumbling, because all of the high frequencies have been filtered out.
Right.
It's the same thing in your lungs and your flesh, is that the high frequencies get filtered out very, very rapidly. And we also know from the oil industry, with the technology that's been developed, is that in order to excite fluid mobilization, in order to aid fluid mobilization, you need a lot of low frequency stuff, not the high frequency stuff.
Right.
The low frequency stuff is what actually generates or aids fluid movement. So
something like they talk about 6 hertz and things like that of
that's right.
Natural,
down there in the 6 hertz, maybe even 1 hertz range. Absolutely, that's correct.
Yeah, for sure. But one of the things that might actually support one of the things you're saying about the energy is I used to do a lot of ultraviolet infrared stuff. We were using it for the counterfeit in China a few years ago. But one of the things is that I've noticed lately that I guess you're aware of UV lights for getting rid of bacteria and things is typically done at 254 nanometers. And that level is enough to damage your retinas, et cetera, et cetera. You have to be very careful with it. And it's because of the energy that it maintains, it can actually go through a number of cells. Well, recently what they've done is started looking at 222 nanometers, which is only 30 nanometers away. But oddly enough, because of the exponential nature of the energy that you're talking about, it decreases enough that the 222 nanometers cannot actually penetrate the tear layer on your eyes. It's just that weak that it can't go through. So that's actually a safe light.
Send me a link to that if you would, please. I think you have my email.
Yeah, it's in the invite.
Yeah, okay. Send me a link to that, and I'll tell you why. Because my son is working as a salesman for a company that is been selling LEDs and light products, and one of their latest products is UV sterilization of circulating air for exactly that reason, for the bacterial suppression.
Yeah, and 254 has been the standard for years. I have one. We used to do them, but now there's 222, and there is one company that's actually making them. So you could actually put them in a room. For instance, in that room that they're there, you could turn them on, and it wouldn't do any damage, which is very interesting. But it goes. So I'll send you the link, but it goes to what you were saying about energy, in that it's logarithmic up at that level.
Yeah.
And that, of course, would be true down at the bottom as well, inversely. And so.
You see, this is why we need to have a device that is, I mean, we know cystic fibrosis back thumping works. We know that. Mm-hmm. We also know that if you tilt patients up face down, tilt patients on their stomach face down, we know that helps. But when it comes to the other ranges of vibrational frequencies, the literature is devoid of information that will give me good clues as to what frequency or amplitude range we need for that therapeutic value. So
on a device
that's why
like
clinical research has to be done in order to make this into a potential method. Yeah.
Yeah. Now, on a device like that, would you be able to produce any resonant frequencies? Are you able to produce anything?
We've talked about that a lot. One of the problems is that all of your internal organs, your lungs, the material around your lungs, your ribs, have slightly different impedances and slightly different frequency characteristics. So there is no resonant frequency.
No, but that's a good thing. My curiosity is, I was thinking about it recently, is, and this goes back to, they think the Egyptians did it way back when, is that, they used resonant frequencies to do various things. And there's a lot of out in the weeds theories about, a resonant frequency, if you got the right one for something this small, because, when you compare a virus to a bacteria, it's thousands of times smaller. One of the things that we were doing was we use ozone to get rid of COVID-19. Basically, ozone in water, it's 3,000 times more powerful, or 3,000 times faster and 30 times more powerful than bleach, right? And it just instantly, as soon as it touches it, it just destroys it. The lipid layer around it gets instantly destroyed when it comes in contact with ozone. And ozone in water breaks down and turns over to oxygen in about 10 to 15 minutes. So what you can do is you can pour it in a river, and that's where all the fish and stuff start growing. So you actually, do good things. We use that in the agriculture industry to clean the water and push it through. But recently we sent one out to the Class 3 facility in Winnipeg, and they're going to test it and see how well it works on COVID, because I've basically got a power washer that you just spray it on any surface from any distance, gone, instant clean, and with no residue left over. Anyway, the point being is that I'm very familiar with the level of strength that the lipid layer has, and it's very, very low. It's one layer thick, and if you break that, the RNA falls all over the place. It's gone, right?
That's why they say wash your hands, because the lipid layer on the COVID-19 virus is weak to surfactants.
Exactly, and and that just destroys it. So, and one of the things I was curious about is, if you ever run across it, find the resonant frequency of that layer. And you're right, all the other things have different resonant frequencies, and they would be unaffected. But because that's so small, that has been one of my curiosities lately. I was just wondering about it.
I think, though, that your point again deserves emphasis, because different structures of different sizes respond to different frequencies.
Yeah, exactly.
And alveoli itself, which is getting up to a millimeter, it is hugely larger than a cell.
Yeah.
Or even much, much larger than the detritus from a cell that has been killed and is broken into particles. Mm-hmm. So if you do a bit of a calculation, you realize that there's about 4 orders of magnitude that you have to do excitation And to excite the macroscopic size above the millimeter, you need the low frequencies and high amplitudes. But for the small detritus, the debris, you need very high frequencies. So that's why we're convinced that you need a range of frequencies.
Yeah, no, I think you're absolutely right. It's kind of like that guy down in Australia that they never figured out how he did it. He was boiling water with a frequency, and he died before he told anybody how he did it, right? But
Okay.
he said, and there was lots of films. So it's always been an ongoing research task to try to find out, how this guy boiled water with a resonant frequency, right? Anyway, just frequencies of particular value have different impacts on different things, and so the area that you're looking at is very interesting. It's I think there's a lot of possibility for that, from various things. And if you had something that would range from one end to the other, of course you could actually try that and see what the effect on it was, right? Go from end to end and just get the results, which is why my question earlier, are you able to basically create any frequency? Because it would be interesting to go through some variations and see what impact they're actually having on these particular.
And that echoes back to the real need for real-time measurements.
Exactly. Oh, absolutely. Yeah. So how do you, once you release this, what's your expectation on removing it? So now you've got it, the viscosity down. It's now sitting there. Now, what's the expectation? Because you can't cough.
You can't cough. That's why I want the patients tilted face down. Gravity drainage works.
Oh, okay.
It works very well in the oil industry.
And it would just drip out. That would be the expectation?
My expectation is that these patients that you see in the image on the screen would be tilted at 7-8 degrees, something like that, with the bottom of their lungs at a higher elevation than the top of their lungs, helping the drainage.
Well, then my suggestion would be, when you get the frequency and you think you're right, go enlist some people with tracheotomy tubes and ask them to give you a hand, because they'd be able to tell you right off the bat how that worked. And because I think they do it on a regular basis, so it would be some positive feedback you could get instantly. And
oh, it's the right posture is not a new idea. It's just to me that I see these images all the time on the media of COVID patients with a chew coming out of their mouth, and they've got their chest at an angle and their face up, which is just making them drown in their own fluids.
No, the prone position, I've been hearing that for a significant amount of time now, and it's been coming out of different areas. So they're saying that's a much better way to do it, because they don't drown, basically, is one of the problems. So you can get the stuff down there, but it's like you say, they just keep filling up with fluid, and the alveoli is damaged at that point. There's all kinds of stuff in there coming from every different direction, so they just aren't working very well. So, but hopefully they'll. I was just watching us in Sweden yesterday, and they said their big problem is oxygen. They're finding that that's the biggest problem, is they haven't been doing a good enough job with oxygen before they get in, and so your best solution is to stop them before they get to this point. So if you
yes, exactly.
Yeah.
The moment you have the first signs of congestion, start the process right away.
Yeah. No, this is one of my complaints about the way they did it, because we had the 1919 Spanish flu, where they didn't have all the equipment that you're looking at on this picture. So basically, if you ever got to this level, you were dead by definition.
Yes.
So their thing is to use it was J.L. Kellogg, the guy from the Cornflakes, who did the hot like heating up hydrotherapy. Basically was his thing, is that it boosts people's immune systems so they don't get to that point. And oxygen is one of the things that they're really complaining about, that they could be doing now, and that could actually do a lot of help. And it seems that they're not getting that because they're not well equipped, especially, and that's the difference between a hospital and a care home, is care homes are typically not all rigged in rooms for oxygen. So now they have to find a different way to pipe it in. Whereas in a hospital, you'd take it off the wall right there. And so that's one of the things that would, my understanding is they're desperate to get that now because they know that that helps so much and stops them from getting to the point where typically at the beginning of this pandemic, they would say, you're not there, don't bother, go home, come back when you're almost dead, and then we'll pull the miracles out and save you, as opposed to, no, stop them from going any farther.
That's such a bizarre comment. Yeah, go home until you're almost dead, and then come in, and we'll see if we can save you. Yeah.
Right, and that just seemed to be such a wrong thing because, the percentages when you work at that level, if you work them backwards, the 25% that, well, actually, I think it's closer to 50. These people in these positions here, they're one of them is going to go, right? It's about a 50-50. And because of that, the more that you can keep out of there, if you could, out of 10 people, you could stop 5, well, you just saved 2.5 people, right?
Sure.
Phenomenal amount.
It's not just saving people's lives. I am completely convinced. Of course, naturally, I'll change my mind when confronted with the facts. But I'm completely convinced that when you do undergo a severe case of the cytokine storm, that inflammation in your lungs, that the damage you're doing is not. I mean, in the Globe and Mail the other day, we read about a fellow, great health, mild blood pressure. That was the only real thing he had.
Mm-hmm.
And he survived intubation, but that was 6 weeks or 7 weeks ago, and he's having a lot of trouble getting back. And a lot of that probably has to do with lung damage.
Exactly, and that's one of the problems because obviously the damage that you look at individual alveoli, if you multiply that by 500 million, it's going to be pretty significant. And there's no two ways that this is going to have long term, and that's exactly right because 100% of the pneumonia and pneumonia-like symptoms are post. It's after you get it and the damage has happened. And, so that's where it's actually quite a problem. If you could stop that secondary damage from happening, although, there is a little bit of a light on that because is it diazepam? Some cheap drug that they're finding works actually quite well with after the fact, once you got it. If you were to take it before, because people want to stock up on all these things, right? It will actually make it worse.
Well,
you take it after, it actually attacks the secondary infection and has a little bit of gain on that. The jury's still out.
Yeah, the 2 principles that I like to apply to my own life. Take an external medicine before you take an internal medicine. That's one. So, for example, if I've got achy knees, I'm going to use Voltaren, which applies ibuprofen externally,
right,
rather than taking it internally.
Yep.
And number 2, if there is a physical benefit, a physical treatment, physical therapy that's beneficial, try that before you start taking drugs. That's the way I run my life.
What they should be doing is putting hot tubs in all these old age homes. That would help. It would help the economy too. All the hot tub salesmen. So, but anyway, no, I think that's good. I think as you analyze, but I'd be curious to look at a variety of spectrums once you had something that could go through and as you're testing, and there might be some interesting possibilities there.
There very well may be. I mean, we just saw on a Globe and Mail obituary here. Let's see, it would be either Saturday or Friday. A young doctor, I believe in his late 40s, who passed on, and this is the guy that actually showed that you can unblock clots in the circulatory system. I believe it's in the arterial side by focused ultrasound, focusing it on a very, very small volume, and it causes micro bubbles, essentially vaporizing micro bubbles to form, and it breaks up the clot. And there's another application of ultrasonics.
Oh, for sure. And I believe there's dozens and dozens of them that if you looked at the right place and you have the right application, this course looks like one of them. So that would be good.
Maybe we can clear plaque from the inside of
that'd be nice. Yeah.
our veins using focused ultrasonic. Who knows?
Yeah, yeah, and it's not unrealistic actually when you think about that, because sound is very powerful. We really don't know a whole as much as we think we do about it, and that's where things like resonant frequencies come into theories and stuff. Because what happens when you overlay a number of things, like a plaque, for instance, exactly. If you found the resonant frequency of plaque, it would do exactly that. Just blow it apart and okay, now it flushes out, right? So yeah, for sure. So very interesting area to look at. Yeah, it's good.
Okay. Anybody else want to discuss?
Yes, Professor.
Isaac, go ahead.
Thank you, Prof. Thank you so much for the presentation. I'm just curious about gravity drainage. Is it, you said specifically that it works in the oil industry. Has it been used in the medical field previously, or is your assessment based on just on the oil industry alone?
Well, gravity drainage will always work because dense phases will drop and light phases will rise. Like, for example, if we have a natural gas pipeline and it ruptures, people always think that the natural gas will spread along the ground and then there'll be a huge explosion. And that never. Methane is less than half of the atomic weight of air. So the methane is extremely buoyant and it just shoots straight up into the atmosphere and doesn't spread on the ground. On the other hand, if you have carbon dioxide that escapes from a tank, it's heavier than air and it stays close to the ground and it suffocates people. So it's the same thing with fluids and gases. In the oil industry, I talked about steam-assisted gravity drainage, but we also have something that we call inert gas gravity drainage. So we inject inert gas into a reservoir, and it moves to the top of the reservoir and then helps displace the liquids downwards where we can produce them. So if your lungs if you have the bottom of your lungs higher than your trachea, than your throat, you've got then a built-in pressure gradient that's going to allow those fluids to drain, and if they drain, then they are replaced by air. So that's the key factor in the gravity drainage of your lungs. Yeah.
Okay, thank you.
All right, I think it's, let's see, 10 minutes to 2. Is there anyone else that would like to make a comment or contribute or ask a question? All right, thank you. This presentation has been recorded and will be posted on the WISE website. If you're interested, please pass the link on to your friends, and I'll be happy to answer any questions via email as well. So I'm signing off now. Take care, and thank you very much.
Thank you, Prof.